I'd like to welcome, obviously, all yourselves and also all the attendees that we've got from all over the world, because we've got attendees from Canada, Italy, Australia, Singapore, Philippines, and as I found out slightly earlier, even from Kenya. So welcome to those people with us. Just to give you a little bit of an update from TOFs, obviously, hopefully you've seen about the cards that were on the presentation right at the start. So obviously, please talk to the office about that. We are in the process of updating our website. So please look out for the new year for the launch of that. But when you're doing so, or watching this, if you might be watching this back on YouTube, please can you make sure that you hit the like button on YouTube and obviously hit subscribe so that you can then get notified of any more information that comes out from us or more videos on YouTube, so you can see all the latest stuff that occurs. So around the screen, I'd obviously like to welcome my co-host, as many of you recognize, which is John Pierce, who is also the treasurer of TOFs. And also on my left-hand side, Dr. Osvaldo Borrelli. So welcome to both of you. The format of tonight will be that we've got a series of questions, and thank you to all those who have emailed the office with our questions. We're going to pose those questions to Dr. Borrelli, and then obviously he will answer them. We're not going to use the chat tonight because we have so many questions that I think we'll struggle to actually get through all the questions through tonight. But if you do have any more questions that we've not managed to answer, please email the office, and Di, Leah, and the team will get those questions to Dr. Borrelli, and we'll get them answered for you and come to somewhere and get the information. So just in case you haven't seen the opening information, just so you know who Dr. Borrelli is, he is Consultant Paediatric Gastroenterology, Head of Gastroenterology Department, and Honorary Senior Lecturer at Great Ormond Street Hospital for Sick Children and the University College of London. So welcome both. And John, let's get started.
Indeed. Well, it falls to me to talk about the first few questions we've got, Dr. Borrelli. So if I start off with the first one that we have, one of our members wants to know, is there much that can be done about dysmotility, or is it something that our OA children just have to learn to live with?
Good evening to everyone, and thank you for inviting me. I'm sorry, we start with a question where, you know, the answer is at the moment we cannot do much. So there is no nothing that can improve the motility of the esophagus. There are some medication have been attempted and we use occasionally, but essentially there is no specific treatment. Possibly in the future, there are a huge amount of research around stem cells. And also in my institution, there are fantastic scientists. They're working, and it's possible that we can create again and a nervous system that can make, you know, possible the restore the motility of the esophagus. So at the moment, you know, the answer is no, and the patient needs to live and learn how to live with this esophageal motility.
Okay, thank you. Well, let's move on to our next one, because we've got so many, as you know. One of our parents says, my daughter is now 2 years old. She's doing well, never had a stretch, but still not confident yet to give her chicken or thicker pasta or white bread because she gets a bit sticky and she regurgitates that, in fact. Have you got any advice for that situation?
First, it's important that she does not have any stricture at the level of anastomosis. So if the fact that food gets stuck is not caused by an anatomical problem, then, you know, it's important that, you know, in the first years of life there is a very strict working with the feeding team. Of course, the advice that, you know, all the patients, she's 2 years old, is quite difficult, but she should chew a lot, you know, the food, and she should be able to, you know, try to eat, you know, almost, you know, different type of food. I want to suggest that it's important to attempt on a regular basis if there is no stricture, because with the time patient can develop, a young patient can develop feeding disorder is something that we should avoid.
Okay. Yep. Thanks for that. That's good. So the next question is going to someone a little bit older, or the patient's a bit older. One of our parents talking about a 15-year-old daughter. She's been referred to a gastro team recently at her local hospital. And the question is it typical for teenagers to begin experiencing further problems linked to poor esophageal muscle function or reflux? They've had many years of this young lady managing well up to the age of 15, but unfortunately that's changed just in the last 6 months, apparently.
In general, it's any symptoms in a patient with esophageal atresia can appear at any moment, during childhood. And this is the reason why the symptoms should be reassessed on a regular basis, because at some point you can develop some narrowing and you can develop, increased reflux. So the symptoms needs to be assessed. Then if something happened and around the age of 15, so it's possible also is absolutely independent from the underlying condition. But say that, the presence of any symptoms in patients with esophageal atresia needs to be carefully evaluated with appropriate investigations.
Okay, that's helpful. So don't ignore it, get it investigated.
Yeah.
And for what it's worth, I'm sure you'd know very well indeed, Dr. Borrelli, but maybe not all of the people on the call would know. It's not unheard of for people in their adulthood to start experiencing all kinds of symptoms, which only after a while they work out are something to do with their OA. We've got quite a lot of adult members who've come to us.
And you're absolutely right. Sometimes the people completely forgot, but the symptoms can appear at any time. So just please, if you have any symptoms, discuss with your pediatric gastroenterologist, adult gastroenterologist, because the symptoms needs to be appropriately investigated.
Okay, thank you. So the next question we have is from a parent who's got a son aged 15, and this son has got an esophageal shelf, as it's described here in the question. He at the side of his joint. He is slow to clear food and he gets heartburn symptoms which have increased. He's now only eating one mashed food meal per day. He's had no contact with his surgeon for over a year. What would you suggest?
That he needs to contact actually is interesting. So the fact is does not have contact with the surgeons, but he should have also contact with the pediatric gastroenterologist. Yeah. Because we completely forget that once the surgery is done, then it's a clinical condition, esophageal atresia. So I think all the patients should have a multidisciplinary approach, not just the surgeons. He needs, again, we're going back to the previous one, he needs to be investigated, and he needs to have at least a contrast study, upper GI contrast, and I suspect needs to have an upper endoscopy, and he needs to have dilatation. So the patient needs to be investigated. It's quite urgent that he needs to be reviewed by his clinical team.
From what the question asks, it's quite a surprise that they're not actively under some sort of treatment already.
Yeah,
that's just my comment. But let's move on to the next.
But he's not been seen for almost 1 year, and the patient became symptomatic. I think they need to seek, medical advice as soon as possible.
Yeah. Okay. Thank you. So another parent we have here is reporting they've got a son who's aged just 3, never had any reflux issues apparently, but something called swishing at the lower part of his esophagus was shown on video fluoroscopy at about 1.5 years old. This child's been taken off PPIs for around 4 months and seems to be doing fine otherwise, as I understand it, not worsened or got better. But how can we be sure that no damage is being created in the lower part of his esophagus, presumably as a consequence of coming off the PPIs?
The guidelines that have been published a couple of years ago by the Joint Commission from the European and American Society of Pediatric Gastroenterology strongly suggest to perform a PHP dense study, which is an investigation can give us a clear idea whether reflux is present or not, should be done after stopping the PPI. So if there are no symptoms, it's absolutely correct to consider the stop to PPI, but after just a few months after stopping the PPI, so a PHP then should be performed. Because sometimes, despite the absence of symptoms, the patient can have abnormal reflux, which with the time can cause significant inflammation in the lower esophageal sphincter. So it should have been investigated at least with the PHP dens, but possibly with an endoscopy as well. So
yeah, okay, thank you. So that's another case of needs to be investigated properly.
Yes.
Yes,
unfortunately, yes, because I want to clarify that, of course, the symptoms are very important. But I think everyone knows, we do not have a specific biomarker that we can easily use and understand what's going on. So the only possibility we have essentially a radiology study, endoscopy, and other type of tests. So, and we need to use those tests to avoid significant serious complication.
Okay, well, the next question we've got is about foods, and do some foods exacerbate reflux more than others? And particularly at bedtime seems to be an issue.
Yes, fat food, they're quite dangerous. Fried food, spicy food. Tomatoes can cause an increased acid, can cause significant reflux symptoms. Of course, sparkling beverage. Then a little bit older. In adolescent or in adult, we have caffeine, coffee, and cigarettes that definitely can make it. But what we should avoid is significant fatty and fatty food and tomatoes. Sometimes because there are these patients are struggling to put weight. What we do, we increase the calorie, and sometimes in increasing the calorie, you also increase the in simple term, how heavy is food. So it's a little bit more difficult to be digested, to be empty from the stomach. You're going to have more symptoms of reflux. So yes, the diet is important. And again, I said before, patient with TOF needs to have a multidisciplinary approach, and that the dietitian should always be involved in the care of patient with TOF.
That's very helpful. Thank you. We've got a bit of a longer question here, but I'll cut it down a little. There's a parent who's saying they're bothered that their TOF OA child sometimes does a cough, particularly at nighttime, as though he's choked on his saliva, and seems not to breathe very well. Could this be the pooling of saliva when he is lying down, or maybe it could be reflux? Could this be prevented or avoided? Because it's already caused 2 trips to A&E, apparently.
That can happen. But can be due to the reflux. But definitely, some patients can also develop, difficulty in swallowing. So here it's important to have an understanding whether we are facing an unsafe swallow or we have a reflux. Usually, I want just to tell that usually the presence of abnormal reflux can be a trigger for increased salivation. So we know that we have those reflexes called esophageal salivary reflex. So we know that an increased reflux is definitely on one of the causes. However, in this case, also an unsafe swallow. So we need to have a speech language therapist involved in the care of this young child. Okay,
that's helpful. Perhaps I could ask you whether you might think in cases such as this, sleeping on a sloping bed would be helpful.
Yes, but the problem with I always suggest to sleep around 30 degrees, okay, with the upper part. But younger the child, younger they sleep down. and the morning after you find them, on the bottom of the bed, and because they try to find a different position. It's difficult. For adults, it's much easier. For children, it's much more difficult. They move a lot, in the bed during the night, and it's much more complicated. But yes.
Okay, that's helpful to know. Thank you. So the next issue that somebody is asking about, Barrett's esophagus. Is this more common in those with TOF OA? And what symptoms should one look out for if one is concerned about it?
Barrett is as significant increased incidence in patients with TOF patients. So, and there are some studies report that up to there is a risk increase up to 40 times compared to the general population. So therefore, the patient needs to be screened for Barrett, mainly in the when they became adults. They should have, after the 18 years of age, they should have an endoscopy, every 5 years. The problem with the Barrett and the problem with other symptoms in patients with TOF OA is sometimes patient can have what we call hypersensibility of the esophagus. So the symptoms has less sensitivity compared to the other patients. So it's complicated, and there is no significant difference between Barrett and gastroesophageal reflux in some patients. So I think we need to just follow the symptoms, or we need to just screen the patient. So there is no specific symptoms can give us an indication about the presence of Barrett or not.
Okay.
It's interesting that Barrett have less sensitivity than others. So it seems patients with Barrett do not complain sometimes at all about symptoms. So it's a complicated field, and that's the reason we need to have follow up, continuous follow up.
Yes. Okay. Well, I think we'd all be happy with continuous follow up if becoming a norm. We'll move on to the next question.
It needs to be a norm. It should be a norm. And the problem that we need to request is becoming a norm. So
yes.
in UK at least we have we are now transitioning all our patient transition, all our patients with TOF, because transitioning is an important aspect as key aspect in this group of patients.
Okay, well, that's fair enough then. The next one is from another parent, as you'd expect. My TOF is approaching 5 years old and her teeth are rotten. Is anyone else having dental issues with their child's milk teeth? Might reflux be causing this?
Yes. Now the reflux is the first cause. We need to think about reflux as first cause, and again we need to be sure that the patient does not have abnormal reflux, the patient is on the treatment for reflux, and so on. Say that and a simple advice for dental issue in patient with abnormal reflux, regurgitation, or esophageal dysmotility is just to use toothpaste and leave in the mouth, and avoid to clean the teeth, and avoid to wash the teeth for at least or drink, and then go to the bed, at least half an hour before. So at least the toothpaste can stay there for a little while before the patient goes to the bed, and they should not drink anything. So avoid drinking just soon before the bedtime can help with some patients, because definitely the reflux. In patient with TOF, we know that they have completely esophageal dysmotility, so the esophagus is not able to clean the saliva properly as in the normal patient. Also, the persistence of saliva and then come back, because of esophageal dysmotility, can cause problem with the teeth. So it's difficult, but definitely the application of toothpaste and avoid drinking, before going to bedtime can help, the healthy of the tooth. Reflux is one of the causes and needs to be explored if abnormal or not.
Okay, well, that's helpful. Thank you. And the last one of the series of questions I need to ask you for the moment anyway, it has to do with consequences of Nissen's fundoplication. Does this have an impact on weight gain, presumably afterwards?
Essentially, no. So what can have an impact on weight gain actually is the presence of symptoms. So if patient develops significant dysphagia, significant difficulty in swallowing, so he's unable to eat and to have a normal caloric input. So if the patient has a less caloric input because unfortunately the Nissen is causing difficulty swallowing dysphagia, yes, that can affect the weight gain. Anyways, the Nissen is very complex to. We are talking about Nissen that actually should not be the anti-reflux surgery performed in patient with esophageal atresia. Nissen is 360 degree. I think the patient with esophageal atresia should have a little bit looser anti-reflux surgery because the problem we have with the patient with TOF is they do not have an adequate esophageal motility. So if you create a barrier at the end of the esophagus actually is unable to overcome the pressure generated at that level. So that's the reason there are some, there's a lot of patients with TOF will require an anti-reflux surgery, but will be useful to avoid the Nissen, but to consider a different type of looser anti-reflux. So there is a very complex discussion about that. Which are the symptoms of silent reflux? Of course, from the word silent is silent. So, but again, is patient with TOF, because we need to be careful, and our threshold for investigation should be very low. I'm so sorry, it's not because I want to be invasive, but I think because on the other side, we need to protect the esophagus, we need to protect the patient. So, and that's the reason it needs again to be investigated. And reflux wage for children, is I think the traditional therapy at the moment are good in managing, the reflux. So I would stick with traditional treatment.
Yeah. All right. Well, thank you very much. I will shut up for a few moments now and let my colleague Duncan take things further. Thank you. Thanks very much on behalf of all our panel, all our participants.
So moving on to reflux medicated related questions now. So this question is, what are the long-term effects of omeprazole and other PPIs? Do they have a negative effect on the kidneys? And when do we know when to stop using them?
Okay, let's try to go in order. Okay, in terms of which some side effects of the PPI definitely have an increased frequency of enteric infection or respiratory infection. So we know that, and gastroenteritis, an increased risk of having gastroenteritis is also understandable because the PPI are used to suppress the production of the acid, and the acid in the stomach has protective effect, so avoid is able to block the passage of infective agents in the small bowel causing infection. Okay, also in the respiratory tract. The relationship between the PPI and other conditions are not so strong, in the sense that yes, there are some evidence, but at the moment they are not so we cannot conclude that, for instance, in terms of kidney issue, so in children, they can cause some problem in the kidney. There is also discussion I can bring on the table, discussion about osteoporosis and the use of PPI. At the moment, there are the relationship is not clear. So it's difficult to state that PPI are clearly responsible for kidney problem, bone problem, and so on. There are also some studies suggesting, for instance, that PPI are able to induce, allergy for their long-term, assumption. So it's always, the pro and cons. There are some patients who definitely require the long-term use of PPI, because here we are discussing patient with abnormal reflux or with abnormal reflux or abnormal motility. So there are some patients, unfortunately, that we require. In those patients, we can consider an anti-reflux surgery if we want to stop the PPI. When to stop them? To stop them is essentially needs to be guided by the symptoms. So, for instance, in patient after the year of life, and they do not have any specific symptoms. Okay, they are learning how to eat, and they are not having any specific reflux symptoms. We can consider to taper and to wean the patient from the PPI and see how the patient does. And then, I said before, after a while, we perform a pH impedance test just to check that there is no pathologic reflux. And then we can follow up the symptoms. The symptoms need to guide us in any clinical decision. Although then at some point we need to have very low threshold to perform the investigation. So if the patient is asymptomatic, does not have any symptoms, it's absolutely correct to consider to stop any medication. Hopefully I have answered the question.
You have, definitely. So the next question sort of follows on from a little bit what you've been saying. This person's written, my son's on omeprazole currently and was on it for year 1 of his life. And then he was advised to wean him off it and replace it by using Gaviscon. Then when they went back to hospital appointment, they told the doctor that it was suffering from reflux at night times, often coughing and as if trying to clear fluid when they're lying down. Is it normal that omeprazole or PPIs give people gas?
Yes. And again, I'm going back to the previous answer. Because the PPI, use of PPI can change the composition of the small intestine bacteria, colonic bacteria. So we can have a different type of what we call the intestinal microbiota, okay? And changing the bacteria in the gut, there are some bacteria, they produce a little bit more gas, okay? And that's the reason we can have more burping and we can have more flatulence, okay? So in terms of using stopping the PPI, I think it's correct when it's done and the patient has not symptoms. It's always correct to consider to restart the PPI for a short period of time to see whether, for instance, in this case, the symptoms of reflux and the cough can settle down. If it's not the case, then I think it's reasonable to understand the cause of the symptoms. Again, if the cough is related to reflux, it's understandable to perform a test.
Okay, that's great. Thank you. So PPIs versus H2 blockers like Famotidine, if I've said that correctly. Yeah. What are the long-term side effects of both?
Again, I have mentioned before, definitely there can be the enteritis and recurrent respiratory infection with the connection with other, like kidney problem and bone problem is still, and there are some description about vitamin and mineral abnormalities, and again, more study needs to come to confirm this association. There are several studies in children showing, for instance, that up to almost 12 years of consecutive treatment with the PPI, essentially there are no significant complication. One of the gastric complications are the gastric polyps, but these polyps are not neoplastic polyps; they are not cancer. It's just due to the gland in the stomach became a little bit more active because there is no acid in the stomach, but no, there are no significant concern about these small polyps, which disappeared when you stop PPI. If a patient needs, however, I want just to say, it's always the pro-cons. So if the patient needs a long-term treatment with PPI and the patient has not had already an anti-reflux surgery at some point, a consideration about then floppy anti-reflux surgery should be considered. But I will not be hesitant to carry on with the PPI for a long period of time, putting on the balance the pro of using the treatment, protecting the esophagus, avoiding significant long-term complication, and the cons of the medication.
Okay, that's great. Thank you. Does a long-term intake of a proton pump inhibitors affect digestion, and does that lead to gut issues?
I have as I said before, the complication, there are, some side effects. We're talking about medication, okay? So it's very rare to have a medication in the market which is absolutely, completely 100% safe. But again, considering the side effects of PPI, which at the moment are quite, not significantly concerning, and considering the needs of such medication in a specific group of children, patient with esophageal atresia, I think definitely everything is in favor of their use. And they are not causing gut tissue. So in the sense, the structure, the neuromuscular function, also the immunology function of the gastrointestinal tract remain absolutely the same. There are some studies actually recently that have shown that PPI also do not have only a function in suppressing the production of the acid. Actually, there seems to have also an anti-inflammatory effect, which is quite interesting. So again, if patient needs PPI, I would always suggest start PPI. And if the patient is symptomatic, I would always try to wean the patient from the treatment. But this is valid for any type of treatment.
Okay. And the next one, I like the next question. I'd love to learn more about preventative antacid use. So what's the current research showing for OF TOF people who do not have symptoms of reflux?
It's very complicated answer, here, because now we know that a group of patients without symptoms have abnormal pathological reflux. So I think it's important before considering long-term treatment, and before considering stop medication, after considering stop medication, after stop medication. I think it's important the patient has got follow-up, and eventually the patient undergo an investigation. In terms of research and long-term improvement of patient with esophageal atresia, I think we should not focus on the antacid. I think it's very important to understand that long-term, research should be mainly on those medication are able to improve the motility of the esophagus and upper gastrointestinal tract. So I would definitely prefer to have a very good medication able to, I'm white hair, quite old. A few years ago there was Cisapride on the market. I don't know if someone of you remember about Cisapride that now has been taken out of the market. Cisapride used to work quite well, okay, on the motility of the esophagus. Maybe it was the best medication. Best for what we call medication is called prokinetics, able to improve a little bit the esophageal motility. I would definitely have the hope that to develop some medication able to improve the motility, or maybe to push very hard on the research on stem cells, because stem cells maybe can give us the opportunity to have again a normal a neural network in the esophagus, and maybe a normal, completely normal motility of the esophagus, which is the key of improving the symptoms in patients with tragoesophageal fistula.
Okay, thank you for that. I'm now going to pass back to John. Hopefully he's going to come on screen and then he can ask you the next set of questions. John.
Yes, indeed. Hello again. I seem to be back in the chair once more, Dr. Borrelli. So thank you for that. The next question I've got is about a child who's unfortunately developed esophagitis. Esophagitis. I'm never any good at saying that word. I do apologise. So this is a 4-year-old child who's recently been diagnosed with this. He's going to be starting a therapy with viscous budesonide. Did I say that right? I think you know which one that is.
Yeah.
So could this have negative effects, this particular medicine?
Unfortunately, it's not so uncommon, the eosinophilic esophagitis.
Yeah.
So the frequency of this type of inflammation in the esophagus seems to be, significant. In terms of budesonide, needs to be, the presence of the. I want just to remind everyone that the persistence of eosinophilic esophagitis in long term can cause stricture, esophageal stricture. I'm talking about actually patient with normal esophagus. So you can understand how much more risky is patient with esophageal atresia, where there is already a risk of developing stricture in the esophagus. So budesonide is an steroids, topical steroids, and of course, long term definitely can cause absorption of any steroids, and that for that reason, the patient needs to be monitored in terms of complication with steroids. Also can cause the long-term esophageal use of steroids in esophagus can cause development of esophagitis, of candida esophagitis, and again, needs to have follow-up. Usually, patients with eosinophilic esophagitis have an endoscopic follow-up after a period of time. So after 12 weeks of or 6 months of treatment, you repeat the endoscopy, and then you try to wean the patient from the budesonide. And after a period of time, usually 8 or 12 weeks, then you repeat the endoscopy just to see if there is again the presence of eosinophilic, because some patients can just have one treatment and they can be absolutely fine. It's also important in patients with eosinophilic esophagitis to explore the possibility of presence of food allergy, because in the eosinophilic esophagitis, I suspect, is much more related to esophageal dysmotility and the stasis of esophageal contents, that level, which cause inflammation. However, there are in some patients with esophageal atresia, actually there is an allergic component. And we know that the cow's milk, for instance, gluten, wheat are the most important allergen, can cause eosinophilic esophagitis. So it's possible that, the patient is so, lucky that he's got two diseases at the same time. So that's the reason it's also important an assessment from an allergist. In terms of monoclonal antibodies, yes, okay, this is the idea of any chronic inflammation in the gastrointestinal tract that we can have specific monoclonal antibodies that, they're very good safety profile. At the moment, there is none really effective on eosinophilic esophagitis. There are some and have been are under studies, but at the moment we don't have a classical monoclonal antibody we can use.
Yeah. Okay. Thank you. So thanks for that full answer. The next question, I feel it's a little bit unfair even to ask you because it relates to chest infections. But are there sensible alternatives other than antibiotics for chest infections? Our question is concerned because her son is already on the highest dose of omeprazole.
Okay, if the patient is, again, it's important to understand that the genesis of this recurrent chest infection, okay? Because if the cause is the reflux, okay, then we can consider in some patients, we combine other medication like alginic acid, Gaviscon. I'm saying just one day, I'm not, have any share with with the company, okay? Which actually is quite useful just to keep in the stomach the gastric contents. Unfortunately, as we have discussed before, that can also be caused by an abnormal esophageal motor activity. And attempt of use some progenetics, there are a few in the market like procholopride or betanecol, so can be done. But also, if we have a recurrent chest infection, of course, there is a need to explore whether there is persistence of tracheoesophageal fistula. It's very rare, but sometimes that can happen. So a combined endoscopic assessment, and esophagogastrodiagnoscopy with the bronchoscopy should be performed and above, because just MRB should be considered because for the persistence of fistula. It's very rare, but needs to be ruled out. If there are specific chest infection, we need to be sure that it's got chest infection. Is also possible it's just an upper respiratory tract infection. And there are some patients, they do very well in prophylactic antibiotics. We use a lot azithromycin, mainly during the winter for 3 times a week, Monday, Wednesday and Friday, and we are able to keep this patient quite free from chest infection for a long period of time.
That's helpful to know. Thank you very much. Well, just a couple or 3 more from me, and then I'll hand back to Duncan if I may. So the next one we have is about a 4-year-old TOF child who's struggling to gain weight, hasn't got a huge appetite and just grazes throughout the day. But this child, it seems, doesn't like milk, yogurts, milkshakes, or even meat and fish. And this has had a stable weight of about 15 kilograms for the last few years, and this is at age 4. What suggestions might be possible?
Okay. I have said at the beginning how there is a significant risk in patient with TOF OA. They can develop feeding disorder. So that is very important to work closely with the feeding team since they are very young. Because the difficulty in swallowing, difficulty in deglutition can cause the refuse of food, because essentially the kids do not want to experience an unpleasant situation. I know some baseline investigation, also some baseline bloods needs to be done, because if never had blood, exclusion of the most common condition like celiac disease, exclusion of other condition like food allergy as cause of this feeding refusal should be done. And again, we don't know if he's got feeding refusal, and the refusal of food can be also symptoms of reflux. And again, and maybe in the end, maybe the child should have been investigated with an endoscopy if there is no increase in weight for such long period of time.
Yes, that sounds pretty reasonable. And we've got a similar question, put much more simply. Our daughter struggles with weight gain. Any suggestions for this? And
essentially, again, a close work with the dietitian is a key aspect in patient. These are, and again, I'm going back to the beginning, okay, yes, of the session. So where there was the surgeons involved, that's it. This is a multidisciplinary approach. So we need to have, yes, the surgeons is a key player, but then we have pediatric gastroenterologist, dietetic, sort team, psychologist, which all, everyone, we need to work all together, because it's not just one domain, but this whole domain needs to be approached. It's not just about reflux, it's about swallowing, it's about everything, it's about bad experience with the food. This child don't feel to be the same like other children in the school, so they don't want to eat because they are much more slower and they avoid to eat, and so on. So all this component needs to be addressed probably by a multidisciplinary team.
Yes. Okay, well, thank you for that. That sounds like a very reasonable answer. Well, the last one that I have on my list here is to do with a child who seems to have become, apparently, dairy intolerant to the extent of projectile vomiting after recovering from episodes of diarrhoea. And this youngster is also apparently not tolerating her normal non-lactose feed, Nutrini feed, now requiring Petisorb feed and lacto-free dairy products. Is there any reason why that might be?
Yeah, I want to just go back to the previous answer, because I forgot one of the key players. Sure. Yeah, no, because I was talking about multidisciplinary team, but I've forgotten and CNS, a clinical nurse specialist, which are a key player actually in the multidisciplinary team, because they are at least we are like in our hospital, because they are they're extraordinary in coordinating the care, and they're always the first point of contact of the family. So I think without them we could not deliver our job. So I do apologize with the clinical nurse specialist, but they're a key player in the multidisciplinary team. In terms of the the developing of cow's milk allergy, this is something that can happen in patients after gastroenteritis, and the cause is simple. Any gastroenteritis, any inflammatory process in the gut infection can cause an inflammation, and during inflammation, the nets of the gut became a little bit wider. So any antigen can go through the net, can cause activation of the immune system, and you can develop allergy. Okay, now this allergy can be transient, so maybe after a period of time, definitely the patient needs to be challenged again with the milk ladder, or it can persist for a prolonged period of time. So this is not related to food, this is not related to TOF, but that can happen in any type of children of patient. Yeah.
Thanks, John. Right, so bowel and intestine questions. Is there any connection with a bowel malrotation and TOF VACTERL association? This person, personally, in our case, there has been an issue in the esophagus, the bowel, and the bottom.
Yes, no, absolutely. So we can have, because there is there can be a developmental issue. So during the development, during the pregnancy, so we can have these congenital abnormalities. So there is definitely an association between those conditions. Yeah.
Okay, thanks for that. And my OA-TOF child was born with an imperforate anus. Despite good bowel control and strength to hold it, can pass 20 plus stools a day. They're always wet. Is there any medication available to improve it? Obviously, being age 4, potty training and everything else is quite challenging. So any advice will be welcomed.
Of course, this is, confirmation of the previous, previous answer. So you can have this relation between the different type of malformative, abnormalities in the gut, malformation in the gut. It's important to understand in this case, this 4 years old, whether he opens his bowel 20 times a day because he's constipated, or he has what we call, fecal incontinence without constipation. So, because in this case, you can use some medication can slow down the motility of the gut, like loperamide, Imodium. While in other case, if you are constipated, then you need to treat the underlying constipation to make sure that the stool are, definitely softer. And in general, he needs to be assessed by doctor, by pediatrician or gastroenterologist, and needs to be treated accordingly to the underlying problem. Duncan, you are again mute.
Sorry, I've done it again. Unfortunately, my dog keeps barking in the background, so I have to keep muting my microphone so he's not barking over you talking. So a couple more questions. When is the best time to do a pH impedance study? This lady's daughter's been offered one at the age of 2, and is that the right time? Is there a wrong time, or can they be just done as and when, as often as they're required?
No, essentially, I think it's the right time. I think around between 1 and 2 is the right time to perform a pH impedance test. Yes. Then, again, if you decide to stop the medication, then it's useful to perform a pH impedance test. And then you follow the symptoms again. I think I think a symptom assessment is the key part in a clinical assessment for patient with TOF. So I think between 1 and 2 is the right time. Yeah.
Okay, thanks for that. And going back to PPIs, can the side effect of PPIs be that they cause chest infections?
Yes. No. We have been. I said before. In general, in a patient with gastroesophageal reflux without TOF, has been observed like PPI can cause recurrent respiratory infection. Patient with TOF, of course, this is a little bit more challenging, okay, because I think we should not, try to convince ourselves that actually are the PPI causing the chest infection, because definitely reflux and esophageal dysmotility is the main reason for chest infection in patient with TOF. So I think we need to be careful in such statement in a specific group of patients. So in this case, I would say yes. In general speaking, yes, but in patient with TOF, I think PPI should be stopped only if we are discussing about absence of symptoms. Otherwise, the patient needs to be investigated before any decision.
Okay, thank you. And one question which did pop up in the chat, I know we said we weren't going to do them.
That's fine, absolutely fine.
But one person's asked, can you go through or name the medication that improves the mobility of the esophagus? Because they missed it, and I must admit, I can't remember either.
Essentially, a couple of medications seems to be a little bit more effective than others are. One is called betanicol, and another one is prucalopride. Okay, there are a few data in the literature. There are experience from other colleagues in the States. For instance, they have very fantastic experience in the Boston Harvard University from Dr. Richard Rosen on the use of prucalopride, and she runs and she's the lead of a hydrodigestive team in the Boston Children's Hospital, and she has quite good experience on prucalopride, and she's quite happy on using it. So, in some patients you can try to use, some medication. However, I want to say we should not always, thinking about we are using medication, we are going to change the clinical scenario. So, what some patients can be tried and see, how they go.
Okay, thank you for that. And those people who are asking for the spellings of it, we will get the office to email them out so that you can then obviously get the right medication, so we know what we're advising on. So, Dr. Borrelli, time has unfortunately come to an end. I want to say a big thank you to yourself, because obviously, and we know that you came straight out of seeing patients and everything else literally at 10 to 7 to meet with us, and you've given an hour of your time, which is precious to obviously yourself. John, thank you for your help again tonight. And please remember, if you are watching this back on YouTube, don't forget to like us, and then obviously you can get all the updates of all the new videos that we've done. So thank you for joining us. I hope it's been useful to all of you. Dr. Borrelli, like I said, thank you very much. And good night.
Thank you so much, and thank you for having me. So it's been a pleasure, a great pleasure. Thanks.
Oh, it's been great. Thank you.